Hi guys, we're going to briefly talk about health supervision. This is chapter 31 in your textbook. I did like the quote from the book, that the words of wisdom that just says, "It is never too late to start prevention. It begins with a genuine desire for health improvement." So when we think about health supervision, we're proactively thinking about preventative measurements so that we can improve health of our pediatric population. So let's get started here. So when we think about the principles of health supervision, we want to be proactive. We're proactively thinking about those preventative measures, like I've said. We don't want to react. If we're reacting, then those measures haven't been thought about. And maybe our patients are sick now. Instead of proactively doing those preventative measures, now we have a sick child on our hand that we are reacting to. We want to make sure we're optimizing that child's level of functioning, ensuring that the child is growing and they're developing appropriately, making sure that we're promoting that best possible health for that child and preventing any injury or illness through those teachings. Educating our parents on those developmental skills will help during those different age groups, and will also let them know what to expect as their child continues to grow. So as we look at the different settings, health supervision can happen in any of these places. It can happen in that private physician's office. Maybe it's a freestanding clinic, like in a retail store. Probably don't see many of those around as much, but it could potentially still happen. Maybe it's our community health department, a nonprofit community-based clinic, daycare centers. Schools are always a really great place to think about those preventative measures. Those school nurses really have to be on top of a lot of things to help with some of those preventative measures. So what does the characteristics of a medical home look like? This is our pediatrician's office. We know that our families are going at different intervals of time so that pediatrician is keeping a really great relationship. And this relationship's really going to last from the time they're born until they're about 18 years old when they transition into that adult world. Medical home provides family-centered care, accessible care in the community, that mutual respect and trusting relationship. It helps coordinate care with multidisciplinary teams. It's available for referrals or consultations. Most of the time, all insurances, including Medicaid, are accepted with these medical homes. Typically, it works with the family to meet that non-medical and medical need of the child and family by interactively working with schools and community agency. And we also want to remember that respect for families' culture and religious beliefs is really going to come into play in these medical homes. So again, medical home is that physician or nurse practitioner. They have that really long-standing relationship where they've built rapport from birth to 18 years of age. It just helps with that continuity of care, coordinating their care, and giving the most cost-effective care. So what are some of the benefits of this health partnership? Entities are in agreement and they work together for the good of the community. When the child is the focus of this health prevention visit, we meet that goal, we give those resources, and we develop that optimal health practice. There, of course, are some special issues when we're thinking about health supervision. Cultural influences comes into mind first. When we think about culture, we know that different cultural backgrounds need to be investigated in this position. Remembering that belonging to a certain culture doesn't really guarantee that they subscribe to all the values of that culture. So each child and family beliefs need to be explored. When we think about the community and those influences, they may be super supportive. The community may be super supportive, or they may lack the education that is needed. So we just need to make sure that we're finding where that community influence comes into play. Each community definitely has its own strengths, weaknesses, and values. So making sure that when we're looking at that health supervision, that we're looking into those community influences. When we think about our chronically ill patients, we may need to bring a team of providers together for the care of that patient. And then our adopted child, we want to make sure we're getting that family and that child those resources for health care that they may or may not have been provided to them if they're coming from a different country internationally. So making sure that if they need to be caught up with their immunizations, if they need to be caught up on any comprehensive screenings for infectious diseases, that we're getting those taken care of in our health supervision medical home. So again, this just kind of goes over those chronic illnesses, remembering that those chronic illness patients may need more frequent visits because they're more specialized. We may need to have coordination of services with different specialties throughout that medical home. So we may have a very multidisciplinary team that we're working in conjunction with. Making sure that we're supporting those families with these chronically ill children, making sure that those families are getting the rest and the care that they need. Making sure that we're coordinating the community resources to help any of their needs. And then just those ongoing assessment of any family needs that may come up. So what are some issues that are covered in the psychosocial assessment? We want to make sure we're touching on that health insurance coverage. This could really make or break a family or a child getting the care that they need. If they don't have health insurance coverage, they may not seek that care. So we need to really utilize our resources in exploring that. Transportation to the healthcare facility is definitely covered under that assessment. If they don't have the capability to get to a doctor's appointment, making an appointment is a moot point. So what can we do? What can we explore that's hindering or possibly not getting our patients to the healthcare facility if they need that? Financial stressors. Families that work 8 to 5 may not be able to get to that physician's office during their office hours. So maybe we need to think about extended hours or urgent care hours because they have to go to work to support their family financially. So they may not be able to get to the healthcare facility during working hours. How is the family coping? This is going to include your parents. What are the siblings' coping mechanisms? And do they have any extended family that might be living with them? And how are they coping with any of the child's medical issues? And then what's the school's response to any chronic illnesses? We know that all schools have a nurse, but that nurse may be shared between multiple buildings. So how can we manage a patient that might need full-time care? We might need to hire some paras. We might need to hire some nurse aides, something to help that school respond to those chronically ill patients that are in the school setting. So 3 components of health supervision include developmental surveillance and screening, injury and disease prevention, and health promotion. And we're just going to touch a little bit on each of these. So our health supervision visit, they're going to come in to their primary physician's office, and we're going to make sure we get a very thorough history and physical assessment. We're going to look at them developmentally, behaviorally, and make sure they're growing and they're meeting those expectations. Do they need any sensory screenings, vision screenings, hearing screenings, any infectious disease screenings, anything like that? Appropriate at-risk screenings. Have they been at risk for anything that we need to screen for? Are they current on their immunizations, or do we need to catch them up? Are they due for any immunizations, and do we need to give them? And then health promotion, remembering we're educating our families on what to expect next as they grow and develop. And if they're not meeting those expectations, knowing that, letting them know that they need to make sure they come back and see us. So components of that developmental surveillance, Trust the patient's parents and what is going on. The parents are going to talk about concerns, and they are all of those concerns. You've got to trust those concerns. The parents know their kiddos better than anybody else. Make sure we're looking at the history of the development. Have they been delayed with each stage, or were they performing well and now they've regressed? We want to make sure we're looking objectively at what we're seeing with the patient. If they are delayed, who do we need to contact to get that patient to the right person for optimal developmental needs? So who might be at risk for developmental delay? These are the patients that we might need to refer on to a specialist, behavioral specialist, or somebody else depending on the delay. Any child that loses a developmental milestone needs immediate and full evaluation. So that's why that health promotion is so vital when we're educating our families. If they're not meeting the expectations of that next developmental stage, those parents need to know what to look for, and if they're not meeting it, they need to come back and be seen again. So you can see there some of the significant neurological problems. If they have a birth weight less than 1,500 grams, that might be concerning. History of hypoxia. If mom used alcohol or drugs during pregnancy, that might cause some neurological issues. HIV infections. Maybe they just don't have, maybe this poor child just has uncaring parents that aren't allowing for those developmental milestones to be sought out. Maybe they just are not able to help with that. So we just need to, these are the patients that are going to be at risk for those delays, and we just need to be aware of those. When we think about injury and disease prevention, we want to look at who is the patient at risk and what are some of those interventions that we need to do to make them not be at risk. So we might look at a risk assessment. This is usually performed by your physician, but as nurses, we need to make sure that those physicians are performing that, because, and when they do perform it, we're going to get instructions further. This is going to include objective and subjective data. It's really going to determine the likelihood that that child's going to develop some type of condition, and it's really just falling into that. What is their risk? Types of screening is also health promotion. So remember, when we think about types of screening, there's two different types. There's universal screenings and then selective screenings. When we think about universal screenings, these are done on everybody. It's that entire population, and it doesn't matter if that child's at risk or not at risk, everybody's going to get it. When we're talking about 0 months to 6 years of age, we can use this Denver development tool. We will look a lot at this tool next week when we talk about growth and development. But this is a really great screening tool to see where they're at socially, with their language, motor skills, things like that. And if they're not meeting those expectations, we can have that conversation with the family. When we think about selective screening, these are, we have determined that our patient is at risk. We've done that risk assessment and they are at risk. And so we're going to individualize some of these screenings and what risk factors we have come up with. So as we think about health promotion, remember, we're maintaining or we're enhancing that physical and mental health of the child. Remember, we're being proactive, we're not being reactive. So we're educating those families on what to look for with the next growth and development stage. If they aren't meeting those growth and development stages, we can identify those risk factors a lot faster if we've really educated those families. Education empowers not only that parent, but as they get older, we can also empower that child to meet those expectations. So let's look a little bit at some of the screenings that we might see as we are working through our pediatric population. The first one is our metabolic screen. This is done as, you might hear it called a newborn screen. So every newborn gets screened for this. And it screens for 26 to 50 of those different metabolic disorders. Some states have mandatory screening. I would venture to say that most states have mandatory screenings. So you might see when you get into your labor and delivery, or you've been in your labor and delivery, that little heel poke that they did on all of the newborn babies. That's that metabolic screen. When we think about hearing screening, the first screening is done at birth, and then they do another one at 6 months, and it just really reduces that impact on development, right? We know, or you will know, that hearing is, newborns hear at an adult level. So if they're not able to hear, it's really going to impact that development of that patient. So we do it at birth, and then we do it again at 6 months. You will also see some of those hearing screens done once they hit that school age, just to make sure there's no concerns still happening. So why do we do these early hearing risk assessments? In the pre-verbal child, so that's that newborn and older, we're going to assess the reaction to sounds, so that auditory skill is monitored. We're going to assess that reaction to sound. Does that child react to the parent's voice or any loud noises appropriately? Any developmental surveillance. Does that child to attempt to vocalize? Are they crying as newborns? Are they responding to voices as they get a little bit older in month age? And then does the parent have any concerns? Do they have any concerns about their child's hearing, or have they noticed any changes in their child's hearing? Remember, the parent knows that child the best, so listen to any concerns they may have. When we think about later hearing risks, we're talking about age 4 years or older. Again, we're talking to the parents about any concerns they may have. Are they having difficulty hearing on the phone? Do they have difficulty hearing people in a noisy environment? So is the child saying what or huh a lot if it's really noisy around them? Are they asking to repeat yourselves? Are they turning up the television up too loud? Are they getting really close? All of those things would be just indicative of maybe some hearing concerns at a later age. When we think about vision, we want to just make sure we're using the age-appropriate picture chart, and I'll show you those charts here in just a minute. The Snellen is usually used after age 6 when that child knows their alphabet. So you probably are all very familiar with the alphabet chart. Just know that it's called that Snellen chart. So these are the different charts. You can see there's the E's that go to the right, to the left, up and down. So if the child doesn't know their alphabet quite yet, you can use that E chart and they can just point which direction the E is facing. That middle is your alphabet chart or your Snellen chart. And then for the younger ones who maybe can't figure out the pointing, don't know their alphabet yet, we can have those picture charts where they can say the square, the apple, the star, the house. It's just a little bit easier for them. We just want to make sure that we're using the correct chart for the correct aged patient. We're going to place that chart at that child's eye level, about 20 feet from them, and then making sure that they read that line by line. When they fail a line, it's the line above that you're going to mark. That's where they can see. That's where their visual acuity would be. And we want to make sure that we're doing the left eye, the right eye, and both eyes to see if they're compensating for any reason. So other types of screening that you might see are iron deficiency anemia, usually done at about 1 year of age, since they're going from formula that has been iron fortified to now whole milk. Excuse me, that doesn't have as much iron in it. We want to make sure they're not already deficient before we get rid of that formula. We also will do a lead screen, usually at 12 months of age. Usually don't see a lot of lead because we've kind of figured out that problem. It's those really old homes with the paint chips, but a lot of those homes have been repainted. Hypertension is unfortunately happening with younger and younger patients because of our obesity issue. So making sure we're checking blood pressures with each well-child check. And then hyperlipidemia, again, with that obesity problem that we're having, This is unfortunately happening with our younger age population. So just other screenings that you might see and be aware of. So we've talked a lot about health promotion. So when I also think about health promotion, I can think about anticipatory guidance. So this just means, what can I educate my family on as the child moves into that next growth and development stage, or as they move into that next year of life? Some of the topics we can think about are oral health care, healthy weight, healthy activity, personal hygiene, and really safe sun exposure. So we can talk about each of these with each age of life or each developmental stage. So when we think about oral hygiene, we think about when those new teeth arrive. We know that our first primary or our baby teeth are going to start erupting between 6 to 8 months, and they're going to keep erupting till about age 3. During this time, those gums are going to be really tender, they're going to be really sore. Most babies are going to fuss about this. And in order to alleviate some of that discomfort, we just need to soothe those gums. We can rub a clean finger on those gums, cool wet washcloth. They have all of those teething rings that you can throw into the freezer. So just really educating those families on how can we, one, get those teeth to erupt through, and how can we do it as comfortably as possible for those kiddos. When they're finished teething, they're going to have about 20 of those primary teeth, and that's just what to be expected. As we continue through our oral hygiene education, we want to just remember that sugary foods and liquids really like to attack those new teeth. So making sure we're brushing early, after feedings, our eating, 4 times a day is really optimal for those new teeth that are coming in. When they wake up, after breakfast, after lunch, after dinner, and at bedtime. Those are really great times to educate those families on when to brush their kiddos' teeth. When that baby's tooth erupts, they need to make sure when they have all their teeth, they're still pretty tender, right? Those gums are tender, so soft bristled toothbrushes, and they just really need a very small amount of toothpaste. We typically don't recommend the fluoride toothpaste for anybody under 2, unless the dentist or the healthcare professional says, yes, that's what needs to happen. We also have to remember that flossing is part of good oral hygiene habit. So once you can start flossing those teeth, it's definitely a good idea. Just another educational point for your families. All right, let's move into vaccines a little bit. So when we talk about vaccines, the first thing that we really need to talk about is immunity. Immunity defined as that ability to destroy and remove a specific antigen from the body. 2 different types of immunity, passive and active. Passive meaning the body's producing the immunoglobulins of one person are transferred to another, right? So mom gives birth, the baby has some of that immunity based off that passive immunity. Active immunity is acquired when a person's own immune system generates that immune response. So we get a vaccine, it's going to generate a response to that vaccine, and it's going to be acquired. Or we get an active disease process. We get chicken pox, right? Our system generates the immune response. We have active immunity, meaning we will not get chicken pox again. So just make sure you understand the difference between passive and active immunity. It should be reviewed for you at this point in your nursing. So different types of vaccines that we can talk about. There's live attenuated vaccines. Those are our live vaccines. MMR, chickenpox are the 2 big ones that can come to mind. Inactivated vaccines, toxoid vaccines, conjugate vaccines, and recombinant vaccines. I don't expect you to know the different types of vaccines. I want you to just know that there are different types of vaccines. And then what are some of the routes that we can think about? Most vaccines are going to go intramuscular or subcutaneous. Intramuscular ones are listed there, remembering that goes into that muscle. It's going to go at that 90-degree angle. We're going to use a longer needle. It's with our little ones, it may not be as long. You're just going to have to really determine which muscle to use and where to place it. And we'll talk a little bit more about those vaccines as we move into the different chapters. Our subcutaneous vaccines are also listed there, remembering it's going into that adipose tissue or that subcutaneous fat at that 45-degree angle. And again, we'll talk about those. Just know that those are your two big ones, intramuscular and subcutaneous. Intranasal is also a option. We did influenza intranasally several years ago. I don't think that's still on the market because it wasn't very effective. Different types of vaccines are listed here. Your diphtheria, tetanus, and pertussis, or otherwise referred to as DTaP or Tdap. DTaP are for those younger ones. Tdap is for that teenager that's getting the booster. Haemophilus influenza type B, or your Hib vaccine, is going to protect lots of our kiddos from things like meningitis, ear infections, things like that. Polio, measles, mumps, rubella. Polio, if you was really back in the 1940s, was a big deal. They developed this vaccine and we've pretty much gotten rid of it. MMR, measles, mumps, rubella. That's a live vaccine. It's going to protect from each of those. And again, we'll kind of get to that as we move through each of these chapters. Hepatitis A and hepatitis B. Hepatitis A, I remember, it usually comes from like contaminated foods, especially if you eat out a lot. Unfortunately, people don't wash their hands every time they go to the bathroom. And so just making sure you've got those vaccines to protect from those. Hepatitis B is more of your chronic hepatitis. It causes more damage to your liver. Varicella is your chickenpox vaccine. So they'll get 2 of those doses. That is also a live vaccine. Pneumococcal or Prevnar, PCV, several different names for that, is just going to protect from some of the, again, bacteria that cause some of our meningitises. Influenza, you should be pretty familiar with. Rotavirus is a diarrhea disease in our kiddos. And so this is a 3 vaccine series that helps just protect from that viral illness that hits those intestines and causes a lot of diarrhea. Human papillomavirus, or HPV. I would imagine most of you are pretty familiar with this. Lots of commercials out there trying to get both boys and girls on board with this one. 3-shot series helps with some of those genes that can cause cancer after you've been sexually active. Warts, things like that. And then meningococcal is for our older teenage population, especially those that are going into college, right? We go into college, we get exposed to a whole bunch of new germs. So that's going to help with those meningitises of that older population. What are some barriers to vaccines? So please be familiar that not everybody is going to trust the vaccines. That's pretty apparent even with our COVID vaccines. So what are some of those barriers? And as nurses, what can we do, especially with our kiddos, to prevent some of those barriers? Access is the first thing. If our parents don't have access to the information, if they don't have access to the knowledge, things like that, they may be more nervous about getting those vaccines. Do they have a clinic or a health system that they can go to get the vaccines? Again, it's going to fall back to transportation. Are they not getting their vaccines because they just don't have the transportation to get there? So figuring out those barriers and helping come up with a solution. What are their concerns? What are their beliefs? Trying to answer as truthfully as possible. Are we going to be able to change the minds of everybody about vaccines? We absolutely aren't. But can we educate everybody about them? We absolutely can. So find out what their concerns are and then just give them the best education that they can make those determinations and determine if they're still concerned, still have those beliefs, or if they want to move forward. What are the health perceptions and experiences? What is their knowledge and information? And do they have any social or family influences that are barriers for those vaccines? Remember, if your patient is coming in to their healthcare provider to get vaccines and they have a runny nose, they may have a cold, they may have a low-grade fever, that is really not a barrier to vaccines. Vaccines don't cause you to get the illness that you're being vaccinated against. It's so if they have cold symptoms, fever, that's not really a good reason to not give the vaccines, but parents will definitely be a little bit more cautious about it. So just be aware of that. And that completes chapter 31 on health supervision. If you have any questions or concerns, please shoot me an email or we can chat about it in class. Thanks, guys.